Yes.
All right. So not only showing you the slide deck, that's a part of it, but also team members who are on the call with us today who have participated in the care of this patient. So this is actually a patient from our clinic I'm going to be sharing with you guys, and just kind of illustrating how a comprehensive integrated team approaches the care of somebody who has substance use disorder. We are incredibly lucky to have such a wide array of talents and abilities on our team. When you can't have everybody under the roof together with you, it's always good to make relationships with those in your community that provide these services. So your care team doesn't have to be under your roof all the time and on your salary roster. They can be all over town and in neighboring towns or neighboring counties. The important thing is that you have a network of people to help you take care of individuals, period. Anybody who's coming to a doctor's office or a medical office usually has all of the aboves. They have case management needs, they have counseling needs, they have at any point in time in their lives, they can have a need for a vast array of different services that all impact how they experience the world mentally, emotionally, physically. So this integrated team approach, I think, is something that is really valuable in substance use disorder care. I think it's valuable in just primary care. So what we're presenting to you guys today is how we approach that intersection of primary care and substance use disorder care. I put a fair number of the individuals on our team on the title slide for today, or just who we are. There may be people who chip in that I didn't include on this slide, and I apologize. Our team has been growing, and this individual that I'm going to discuss with you all, she has been in our care for a few years. So a lot of the members of our team have had opportunities to work with her. So we do not have any disclosures that I'm aware of, any of us. And so basically being presented to you guys as a case study, a 28-year-old white female who's a G2, P2. She presented to us shortly after having her second child. She'd had a 9-year history of illicit buprenorphine use, meaning she'd been buying her own buprenorphine, not part of a clinic or a treatment facility. With her most recent pregnancy, she had established care with an OB and in town, and was given a prescription for buprenorphine and was tapered down as part of her treatment plan in that obstetrician's care to 4 milligrams a day. She was then referred to our office after she'd had the baby, and as part of our intake process, engaging the individual in front of us, making certain that they feel welcomed and comfortable, and that this is a place where they can share without fear of bias or stigma, reciprocation for some activities that might not be well looked upon, just by the kind of negative nature of the words that we use to describe it, like in the slide already, illicit buprenorphine use. Illicit sounds really horrible, but she was trying to take care of herself the best way she could, that she knew how she could, and access what she knew she could. And with the pregnancy, she was able to re-enter medical care and receive an actual prescription, but the dose she was getting actually was not sufficient for her cravings. And so she was still having to supplement her dose and was taking 8 milligrams a day. And then her baby did spend time in the NICU, largely because there was a placental abruption that required an emergency C-section. She did deliver about 8 weeks early, and then she was dealing with elevated blood pressure and preeclampsia as part of that pregnancy as well. So it wasn't an easy pregnancy at all. And then the aftermath of the pregnancy, the trauma of having an emergency C-section, and then the fact that it was a placental abruption, that's a pretty scary situation to be in for mom and baby. And then just dealing with the whole blood pressure, preeclampsia, it makes you feel like garbage. So she was having a pretty rough go of it when we first got to meet her. Medical history wise, polycystic ovarian syndrome. She, of course, had follicular cysts on her ovaries. The C-section, she had her tonsils out. Family history, diabetes, hypertension, lung cancer, heart issues, colon cancer. It comes up later in the slide set too. There is family history of substance use disorder. So when she comes to us, her problem list includes a variety of things that, because she's coming to us for opioid use disorder, that's definitely on her list. But it's complicated, right? Because she's got an opioid use disorder and she had major surgery. She had intra-abdominal surgery in an emergent situation with that C-section and a placental abruption. She also has nicotine use. She is obese. She has chronic pelvic pain. She has issues with her extremities. She's got carpal tunnel of her wrists, her left ankle. I think she had broken it at some point in time, and just, it was never quite right. She had a lot of rolling of that ankle, a lot of pain associated with it, anxiety. And as part of our intake, we found out that she had difficulty with reading. We'll get into that a little bit more. Intake vital signs. 5'5" woman who weighed 242 pounds, so elevated BMI. At the time of her intake, we were collecting ACEs on our patients, and that's the Adverse Childhood Experience Screener. She scored 5, so that definitely puts her at risk for long-term poor outcome medical diagnoses, as well as puts her at higher risk for, there might be a number of cats going crazy in my house, so just ignore the sounds you hear if you hear them. I am. Also increased risk of substance use disorder. So no surprise, she's coming to us with an ACEs of 5 and struggling with opioid use disorder, elevated PHQ-9 and mildly elevated GAD-7. So depression and anxiety screeners. Blood pressure a little bit up, but not hideous. But at the time this was done, 25, 26-year-old woman, not ideal. Behavioral health, she did have history of depression in high school. She started using buprenorphine for her depression when she was 17 years old. She had about a year exposure to methamphetamine between 19 and 20, and then smoking nicotine and caffeine in the form of 2 liters of Mountain Dew a day. With her psychosocial history, this is kind of where we get into a little bit more about family background. With substance use disorder, her father, and these are where some of her ACEs come from, had substance use disorder, history of incarceration, and emotionally abusive. So that right there gets her 3. And interestingly, her mom worked in a prison. Even though they got married, her parents, because of an unplanned pregnancy, they did divorce when our patient was 19 years old. And 2 of the patient's siblings have substance use disorder as well. And our patient cared for one of the siblings' children for several years because of that sibling not being able to parent. She is a middle child, 2 older sisters and a younger brother. She is currently married. Her husband works as a plumber. She does have a high school diploma, but is actually functionally illiterate. She had all of her school lessons read to her. So she basically went through high school orally. She didn't read, someone read to her and she provided answers. So her ability to learn and recite back information very much intact. This actually got in the way of potentially getting her some disability because she basically went through school where they didn't mark that she had any type of disability, though she was functionally illiterate. So she had a high school diploma, but still unable to read at the time of graduation. She is unemployed, works in the home with caring for the children, but also the illiteracy curtailed her ability to get a job out of the house because she's not able to read. And this inability to read really contributes to a lot of the anxiety that she has. She does have insurance. So this made some of our plans easier to access. You can imagine some of the things we might want to do for her would be challenged by lack of insurance. They do have their own home in a remote rural area, so access to certain services might be challenged, though she does have her own vehicle. Household income for 4 people is less than $10,000 a year. She does not, however, have a mobile phone, so kind of tied to a landline for communication. Part of her intake included reviewing her strengths. What she identified in herself was strength of love, kindness, honesty, and spirituality. And on provider's assessment, found her to have a strong motivation for change, commitment to family, the fact that she has health insurance, as I mentioned, makes access to certain services possible. She does own her own home and she does have access to reliable transportation. So all of those things are really strong positives for her being able to access care that we maybe discuss and she would like to utilize. And then her hobbies. And when I was looking at this, it's great. She has some hobbies of taking care of children, board games and card games. So she does enjoy games, but it's kind of a short list of hobbies. And it's not unusual for us to find this in our patients. A lot of times, especially when their substance use disorder starts, is an age where they are really finding the things that they like to do. But when their time and energy is absorbed in using, seeking, and recovering from substance use, they don't really get to dive deep into discovering what their likes and interests are and engaging in those activities. So this was at intake. I would like to go back in next time she's here and ask her if she's developed any more interest or realized there are things that she once loved that she was just starting to get into at the age of 17 and has now gotten back into them and doing more. So some things to think about and that I want the team here on the call and other individuals to chime in about are what barriers to whole or total person care might you guys recognize in this individual? What kind of interprofessional interventions? And that can be different disciplines other than medical. It could be medical, different specialists that we might want to call on to assist. And 2 areas of priority to address with her. When you look at her history, what are 2 things that you guys can think of that she might that you might want to put on top, recognizing with whole total patient care, whole person care, we're actually going to prioritize as long as it's not life-threatening. It's like the chest pain that I'm having, substernal crushing like an elephant on my chest, doesn't need to be 4 or 5 on the priority list. We kind of get to put that one at the top. But if she's got some areas that are more important to her than what we might think, it's important to pay attention to what her preferences are. That goes a long way in investing in the rapport that we're building with the patient, but also it helps them feel heard, seen, and validated when we recognize that it's their agenda that is the most important agenda, again, barring any life-threatening issues. So I'm going to go back to her problem list just to kind of have that in front of us so we can kind of think about what are some approaches to whole person care, interprofessional specialists, individuals we'd like to have involved in her care, and then anything as far as top priorities that you would like to help her address. So I'm looking for members on the call today that have worked with her to kind of help carry the conversation forward. But does anybody have any thoughts about possible barriers she may face?
Well, she had a number of barriers. Obviously, she had the reading was a barrier. It's hard to do very much, particularly with a lot of her case management needs. You know, with a lot of the resources that we give to people, there are a lot of forms to be filled out, a lot of things like that. So the reading was a big barrier for her. Transportation, and then the not having a cell phone can be a barrier as well. So she did have kind of a lot stacked up against her to begin with.
With transportation, they have a car? Is it one car that they share, or does she have her own vehicle? Do you remember in the beginning?
I don't remember in the beginning.
Okay, I don't either.
They've got 2 now, I believe. She
Okay.
drives herself to her appointments. I don't know when she first came to see us if that was the case or not.
Yeah, I don't recall.
So at the very beginning, they were sharing a vehicle. There was one vehicle, now that they have 2 vehicles. Hi, I'm Veronica. I'm the case manager. Sorry, I popped in late. Working with this patient. So at first glance, you know, as a case manager, you see, okay, then we need to address the reading disability. But that was something that that drove her anxiety more than anything, especially social anxiety. And in order to get her up in income, like to go find a job, to do things like that, because she I don't think she even wanted to admit early on to just anybody that she was unable to read. So she just wouldn't tell people. I believe, if I remember correctly, she did get a job for just a couple of days somewhere, but didn't realize that Even being able to read the register was hard for her. So I do know that we referred her to, and forgive me, I can't remember the name of the place, but to help address the reading disability, we did refer her to somewhere that would help with that. And that even was a barrier, if I remember correctly. It was a lot of because I think it was for adolescents and not so much for adults. So, but I know here recently that what has helped her really overcome her anxiety was at first she was not willing to do groups, and then we kind of kept just talking to her about the groups that we had, and we had an art therapy group, and that was one of the first groups that she attended, was an art therapy group back in Christmas. And she kind of saw how she could engage and still have a good time without being worried, because I had the previous knowledge of her being unable to read. I didn't call on her to read certain things. I didn't, I was very mindful of that. And so she was able to become comfortable, and she came to a second one, and because she came to the second one, she was able to open up and actually talk to other members there, so that helped with her anxiety some. And I was able to build a rapport with her at this point, to where she kind of came out more, and she trusted me to be able to tell me what really was going on in her life, and that she really didn't want to, she was uncomfortable with working and she wanted to apply for disability. And so that's then where we went. And unfortunately, there's still a barrier because the disability does not, offices do not think that it is a disability, and she was denied it. So
I can't recall the exact name of the place that we referred her to either, Veronica, but I do think it's associated with ETSU, and I don't know if it's like our speech language pathology.
Speech and Language Center, yeah.
Speech and Language Center.
The NAVE Center.
The name, yeah, it has a lot of names apparently. No wonder none of us can really remember it, because it's got a bunch of different names. But there was a lot of back and forth, and just kind of keeping that ball in motion until we finally got it to the place where they started working with her. And she also was identifying some similarities between her initial struggles that led to her just kind of getting put on the side. She saw the same thing happening to her son. I think when we started working with her, he was just entering kindergarten. So that's actually another area where we helped her navigate and get her son, like let her know what she needed to do to get her son connected to services. So I think he also ended up getting some support in that area as well. But it was really sweet. Like, she'd come and talk about what she was doing at the NAVE Center, and like she's working on sight words, and like she's actually getting the help and attention that she needed, should have gotten when she was in the public school system, but didn't, for who knows what number of reasons why, but she didn't get them. And also just the pride in herself for learning, and getting something achieved that she hadn't gotten the help for in all those years. But also pride in getting her son the help that she needed when she was his age, and making a huge difference in what his life course is going to be like, because he's getting the support she was not able to access. So again, for a myriad of reasons that she didn't get the help that she needed. And some of them probably will go unnamed forever, why she didn't get what she needed. Because that has been a huge issue. And priority wise, yeah, it was a huge priority, but it couldn't be number one because of all the connecting of services and people and explaining, and why is she this age and we're sending her there, to get people to understand what we were trying to get done and why she needed that help. Once it was figured out though, they got her in and they worked with her. But priority number one, there were a few things that we had to do first for her. And Caleb, I know you were involved a little bit later than her first presentation to clinic, but do you recall kind of where we first started with her as far as the first priority we were addressing?
I don't actually, with all of the, I think dosing was probably happened day one, if I had to imagine. I do know that the attempts to get her into the NAVE Center, that started pretty early as well. But from the medical side of things, the dosing was a big issue because she was being underdosed and was supplementing from outside sources. And so trying to get her on a more appropriate dose that would address her cravings and keep her away from having to go seek elsewhere, I think was one of the initial things that I don't actually know that happened day one, but I imagine it probably did. That's from what I remember, the reading and the dosing happened pretty early on.
Do you recall, what is she on right now? What dose is she on now?
She's on 16 right now.
Okay. And that's, from what I remember, like she was able to supplement herself up to 8 milligrams. And I think that's where we started because that's kind of what she came in on. So we gave her an actual prescription to cover what she was doing day to day. But I think we found in time that the 8 milligrams still didn't cover her cravings. And so that's how she ended up on the 16 milligrams. It took us over a year to get her into the NAVE center. Part of that was COVID. So we were doing some of these things during COVID and people not being seen, or very small numbers of patients being seen in person. And that was like already established patients. It was a lot. It took over a year of that, at least a year, to get her into the NAVE center and start working on her reading. There were constant delays and reschedule. It was a frustrating mess for a while, I'll be honest. But I also remember at some point in there, the obesity, it's like things that feed off of each other, right? She's obese, she's got high blood pressure, and she can't really exercise. Like, well, get out there and exercise. She can't walk on that left ankle. And so that was one thing that I know we did within that first year of working with her, was getting her connected. I think the ankle was the first thing we did, was getting her in to ortho and having them address the ankle. Because again, it was one of those things that the follow through, just connections weren't happening. And so like a duck on a June bug, we got on that and made certain that the connections were made and she got the care that she needed. So we were also having to manage pain. So she first comes to us post-operative, basically, and dealing with pain from that. And then we had to get her through the pain of her ankle. And then she actually ended up having 2 carpal tunnel surgeries and navigating, controlling her post-op pain with that, and being on buprenorphine and having post-operative pain. Luckily, with the surgery like carpal tunnel, they can just do a local block. However, with the number of our patients who have opioid use disorder, even people who use nicotine, their pain thresholds are forever altered because of that exposure, especially ongoing use, like with nicotine. So I do remember there was some back and forth and up and down, everything appropriate. She was never in a position where we were concerned about her doing anything inappropriate with her medication. She has been, the whole time she's been in our care, honestly, an ideal patient. And I'll go ahead and say it, kind of an easy patient. She is very agreeable. She is interested in doing what she needs to do to make her life better so she can make a better life for her children. She's very motivated for change, and she wants something different for her life so that there can be something different for her children. But we did navigate 2 carpal tunnel surgeries with her and manage her pain in the setting of taking buprenorphine and having an opioid use disorder. Another really big thing that happened was her drinking habits. She quit drinking Mountain Dew. And we love a harm reduction approach in our clinic, kind of like, what can you do? Instead of like, you need to do this and you need to do that. What can you do? What feels approachable to you? So we actually put her on we do this for individuals with alcohol use disorder too, and they're not quite ready to quit, is we work with them to taper. Or the idea of, transitioning from like alcohol to benzodiazepine for alcohol detox, we'll work with them to taper. So we worked with her to taper her Mountain Dew consumption, and she is currently abstinent of Mountain Dew. So that's a pretty huge thing. And she saw weight come off as a result of that.
And she has lost 49 pounds.
So she's under 200 now, Tanya?
Yeah.
That's awesome. So you can see the things that I'm talking about actually opioid use disorder is just kind of woven in there. It's one of the fibers in the fabric of this individual. There's a lot more going on with her. And in our addiction medicine clinic, we're a fellowship, right? We're focused on substance use disorder. We're also addressing primary care needs. And I think it goes both ways, where if you're a primary care office addressing substance use issues is also part of your job. You ask the questions. And a lot of times you have to know the resources before you ask some questions, because if you get positive answers and you're like, well, I don't know what to do with that. Sorry, I asked you. You need to know what the resources are so that you can help direct your patient. And that's kind of why we're here with this echo and why we're having this talk right now is, what are the resources? What are ways that we can help and manage our patients and all the different things they bring to us. And in primary care, that's one of our points of pride, is that we can help patients with many different things. We've been trained to take care of the whole person. And if it's something we can't do, we recognize our professional limitations. We connect to members of our community and refer on, like we connected with the NAVE Center. We connected with orthopedics. I think she's been to PT as well, like for the ankle issues. So integrating not only under our own roof, but with other providers in our community has been vital to improving the health and well-being of this individual, which has the cascade effect of improving the health and well-being of her children. Ideally, we are increasing resilience in our patient, which means that her children have fewer ACEs. And because they have a mother who's dedicated and invested in them, because she has the time, energy, and ability to do so, they also develop resiliency. And therefore, we're working towards preventing substance use disorder and chronic medical disease in her children in the next generation as well. My voice has been pretty dominant in this conversation, so I'm going to ask if anybody else has other thoughts or experiences with her. Is everybody okay if I take the share screen off and I can see all your lovely faces? Is that okay? I am not hearing any no's, and what faces I do say,
Yes.
we can take it away. It's gone. Okay, excellent. And we've also had a few other people join us. Jack, if you don't mind to unmute and introduce.
Alrighty, I'm Jack Larsen, clinical assistant professor at the ETSU Addiction Medicine Fellowship.
Fantastic. It's good to have you joining us, Jack. Thank you. And then I've got, nope, it went away. It did have a U16, but it's not there anymore. I don't know who that was. If you come back, unmute and introduce yourself. Oh wait, you're not here, so you can't hear me. Does anybody else have anything else they want to contribute about this case, or instances where you have engaged in primary care unexpectedly, like you thought you were in there to do one thing and you ended up really focusing more on primary care needs, or you were there to do primary care needs and you found yourself focusing more on a substance use concern?
I did just want to point out the when after she got carpal tunnel surgery, and where income was a big thing for all of them, and where their family needed more income, and she was too socially, she had too much social anxiety to go get a job. She pulls copper off of wire and she sells it. She's very resourceful, and she said after her carpal tunnel surgery, it doesn't hurt as much, and she is able to provide more for her family. And so even just that, addressing the carpal tunnel and doing something that, and that's something that she enjoyed doing. She said, I can make a little bit of extra cash while my husband is working and I'm still sitting at home with my children, you know. So it just shows how everything is kind of connected, and where just the carpal tunnel surgery put extra cash in her family's pocket.
That's awesome. I didn't know that, Veronica. I didn't know she was doing that. That's pretty cool, actually. She is resourceful. That's really cool.
This is Dr. Boaz. I was curious about her support system outside of the medical professionals.
I know she has a husband. I've not gotten anything that makes it seem he's anything other than supportive. I don't know. Family wise, do you guys know anything? Like, is she in contact with those siblings, or are both of her parents passed away? I feel like
Her
No, her
father is incarcerated. I'm not certain about her siblings. She does, I think she's got some support through their church. That I think that's all that I recall really hearing about.
Feel like her social anxiety has kind of kept her pretty close to self and close to home. And I'm not certain like if she's still going to the Nave Center and getting help with reading, just where she is. It's one of those things, like as far as identifying what the issue is and why she wasn't able to learn to read as a school age child. I do not think that she is, because she's getting the services she's getting, she's going to be reading, War and Peace anytime soon, ever. She will always have a deficit when it comes to her literacy, but just being able to possibly get a job where she needs to read a little bit, but not a lot. I think she probably still needs some help with filling out forms, especially if they're more cumbersome forms, like filing disability paperwork. But I feel like that her inability to read has really made a difference with her reaching out to other people and making friends, even because she is very protective around that information. So her church, yes, she does get support through church, but I don't really know that I could say that I know much about a friend group for her. But I feel like that's been a topic of conversation where it's like she's not really worked to engage in developing and maintaining friendships because of kind of the self-stigma with her reading deficiency. But she does have some support outside of clinic. Any other thoughts or experiences with this particular patient, or instances that you find yourself engaging in not really, like, it doesn't seem like you're doing anything for the substance use disorder? It comes up a lot actually in our clinic where they are still using what they're using, but it's much more we're addressing case management issues. For example, we had a patient that was continuing to use methamphetamine. It was winter. Methamphetamine didn't make her feel cold. She forgot she was cold and hungry when she used meth, because she was living in a tent in February. And it's an example I bring up a lot for this. So some of you guys know, I've heard this example before and know exactly what I'm talking about. But once we got her a door with a lock, a roof, 4 walls, indoor plumbing, and an HVAC, she did have cessation for a period of time. She's now again abstinent and has had a really long period of abstinence from methamphetamine. But getting her in a house actually did make a big difference in her methamphetamine use. There was no amount of counseling, no amount of underlying diagnoses, being diagnosed and treated with medications. That actually wasn't it. That is not what made her stop using methamphetamine. It was getting a roof over her head, literally. So sometimes in order to address the substance use disorder, you have to address a different aspect of their life, because it's not going to stop until maybe someone's PTSD is addressed, someone's social anxiety is addressed, someone's housing situation or food insecurity is addressed. And that's not a prescription. It's a lot of hard work and determination for some of those things.
Yeah, I think that when you're looking at this case, for example, with the very limited income that they have, it would be hard to really expect the patient to do too much about their diet, for example, or as you said, with the physical, pain and all those stuff, to ask the patient to do any exercise. So it would be, really good to focus to find resources that help the patient to make extra money, which Veronica says that was one of the things that collecting the copper after the carpal tunnel surgery. But still, with this disability, I'm looking at it right now, I'm thinking about it, that if someone has a difficulty seeing, the glass maybe, would be the first thing comes to help to, but if someone doesn't get the correction of that, visual ability, then we need to convince the patient to look for the jobs or help the patient to choose between the jobs that does not require any reading. So those resources may be unknown to us, but we can always get some specialists that able to, jot out the list of the job that the patient may be physically able to do it, and it's a serial kind of the work that does not require any kind of the reading, and just give an option to the patient to choose from if there is anything local available. With the low income that they have, I think the dietitian can, help the patient if she's interested to lose weight, which she has done a good job by just cutting back up the Mountain Dew, but it's still, I'm assuming when someone has a $10,000 or less than $10,000 a year income with the family of the 4 or 5, then everything has to be, really managed somehow so nobody goes hungry. But the quality of the food would not be good. So a dietitian may be able to, help them to have a better quality of the food by giving them some option. So those are the things that doesn't come as, in the first time to your mind, but those are the things that helps the patient. And I think that having a dietitian, at least, as needed in a team, would be a perfect, situation on this particular case, for example.
Yep. Yes, it would. A dietitian would be really awesome. I think a dietitian and a dentist. I didn't come up for her dental issues, but that is a super common one, is dental. And that one, that is hugely impactful because people don't want to smile. In some ways, with COVID and the mask, for some of our patients, they were like, yes, I'm actually going out in the world and I'm doing things because I have to have on a mask and nobody can see I smile freely. No one's looking at my teeth and I don't have to feel self-conscious about it. But that's definitely one. They hurt, they get infected, food tastes weird, they can't chew, they hurt, they're always in pain. So yeah, we need a dentist and a dietitian. So if anybody has some spare dentists or dietitians, send them our way. We'd love to have them. Any other thoughts, comments? Hi, TJ.
Hey, I kind of have a weird take on a lot of this. When you were going through the history, and I was looking at all of the musculoskeletal injuries and the history of parents with substance abuse as well. I kind of come at things from a different background, just based on my background. So I'm finding a lot of my patients that come in with anxiety, alcohol use disorder, or other substance abuse, I screen them from a musculoskeletal perspective as well. And a lot of them have hypermobility spectrum syndromes like Ehlers-Danlos. There's a really high population of it here. And a lot of times associated with that, there's histamine intolerance and mast cell activation syndrome. So a lot of people, once I kind of address their histamine problems, because elevated histamine tends to lower dopamine, which then kind of keeps that cycle of addiction going. So a lot of times, if I'm able to stabilize their histamine or stabilize their systemic inflammation, a lot of times that helps them to cut back on their substance use. It's kind
That is fascinating.
Yeah, I found that a lot here. There's a lot, and I'm saying this because it relates to primary care, because they have a lot of histamine related issues that get missed in primary care. So we have primary care here, so I can collaborate with them. They have GERD or rashes or other symptoms related to histamine, and that's fueling the anxiety, fueling the addiction. So kind of addressing it from that whole health perspective, getting on a low histamine diet, that kind of thing, it really helps a lot.
Right.
So yeah. That's
fascinating. So because Rick here, and I'm going to point that out, he's got a number of articles that he shared with us. So take a look at those. A lot of kind of interdisciplinary models, primary care focused articles. So sharing articles is a big thing that we do. If you have your easy to lay your hand on some articles and things related to this, TJ, we would love to have those to look at. So we can learn more and educate ourselves more. And if it's something that you come across something in the future, even be like, I bet they could use this over there. Send it our way. We would love to be able to have a chance to look at that and share that with others as well. So I'd like to learn more about it. So please send it our way.
Well, thank you.
Thank you. That's really cool though. Thanks.
Yeah, I'm working on my DNP, and my target is nutritional psychiatry. So
Oh,
I have a lot of cool information about that stuff.
well,
So
I don't know. Offline,
I'll
I
send
might
it
be
to you.
getting in touch with you, be like, hey, you want to do a topic discussion for us?
Yeah, I'd love
Because
to.
that's
Yeah, thank you.
fascinating. All right, cool. Well, we'll talk later, TJ. All right. Good deal. Any other comments or thoughts for today's topic? All right. So I am not one who wants to belabor a point or beat a minute to death. So if we don't need to squeeze more out of this toothpaste tube, you know what? You guys can have your time back that you had dedicated to us. Maybe do something nice for yourself. I know I am. I'm going to eat some lunch. But January 24th is our next session. Death of Despair and Resiliency. Michael Meat is going to be providing that for us. He's an MPH, and he has a lot to say on this topic. I'm pretty excited about it. So make certain to come yourselves, make certain to tell your friends, and bring them along, because I think it's going to be a really fascinating topic when he joins us in 2 weeks. This actually got pulled from February 7th. So our February 7th is to be determined at this point in time. I'm hoping that's when we get to have the obesity and substance use disorder talk. That's another one that I think is pretty fascinating. That interplay, there's a lot of overlap with some of the behaviors and needs, because foods are going to hit on that dopamine releasing centers in our brain as well, because it's one of those things we need to do to survive, because it feels good. So we want to do it more and more. And then on February 21, identifying and managing complications of substance use. So we're going to be looking at infection type things. So septic endocarditis, osteomyelitis, things like that. So some of the things that we see happening when people have ongoing substance use, complications related to that substance use. So that one's also going to be a really good one, because, we just do good stuff here. Thank you everyone for joining us. We appreciate you being here, and your time is now yours. You got about 11 minutes back. Thank you, everyone.